All right, good evening, everybody, and thank you for joining us tonight. I'm gonna basically speak about getting started, the recommended testing that we do for our patients who are pursuing treatment with our practice. Just an overview of the testing that we recommend. Fertility involves, I always tell my patients, four main parts. We need an ovary with eggs, we need fallopian tubes, we need a uterus, and we also need sperm. So when we do our testing, it basically encompasses these four main parts, and I'll talk a little bit about how all of these parts are tested. So the first part is the ovarian reserve testing. So you see anti-Mullerian hormone on the screen. That's one of our main tests that we use to get an idea of where your ovarian reserve is at this point. There are other traditional tests that we use that are usually cycle dependent. The good thing about the anti-Mullerian hormone is that it can be drawn at any point in your cycle, and there's less cycle month-to-month variability compared to some of the more traditional tests like the day 2 or day 3 FSH levels that we've done in the past. We still do those tests. The anti-Mullerian hormone is just a little bit less variation. When we look at this result, it's not a predictor of pregnancy, but it does give us an idea that if you were to pursue treatment with us, what are the predictors that can give us an idea of your ovarian response. So when you look at this little gauge over here, we usually say an AMH over 1 is considered kind of within a normal range, but we do expect it to fall below 1 after age 40. So depending on your age and time when you're getting your reserve testing, we'll talk to you about where you stand compared to women your age, and talk to you a little bit about what these results mean for you individually. And then for the further female testing, we also like to think about the uterus and tubes. So the physical test is what I tell patients. At this point, we like to consider two options. The first option is what we call our gold standard, and it's called a hysteroscopy. So if you've heard of a colonoscopy, this is a hysteroscopy. It's a tiny camera, smaller than a pin, and it's used to actually take a look inside the uterus. There's no cutting on your tummy. There's no big incision. It's an outpatient procedure. You go home the same day. This type of procedure probably takes us all maybe 30 minutes to complete, so it doesn't take very long. But it's a tiny little scope. If you look at the image A, you can see an idea what it looks like as we enter the intrauterine cavity. And when we view the cavity, we're looking for things like fibroids, scar tissue, if you've had prior uterine surgery or prior pregnancy or miscarriage. And we also can see the openings where the tubes actually leave the uterus. So while we're also checking to make sure the home for where the baby's gonna be looks good, we also can check your fallopian tubes at the same time. So that's called the tubal catheterization. So we take a tubal catheter while we're doing the scope, and we basically introduce it to the fallopian tubes and we flush them with basically it's called Omnipeg. It's a test that fluid that we can see under X-ray, so we can actually see if your tubes are open. So when you wake up from this procedure, you'll get a lot of information. You'll know if we saw something like a polyp, fibroid, or scar tissue that we diagnose, but we can also remove and take care of at the same time. And when you wake up, you'll also find out whether your tubes are open or blocked, okay? Now, the hysterosalpingogram, or HSG as it's called, is a test that may be ordered with your OBGYN. This test does not require anesthesia. You actually will go to a radiology suite or maybe our surgery center where we actually place you in the same position as when you're getting a pap smear. Sterile speculum is placed, we take some dye, inject it into the uterus, and we actually can watch the uterus fill with the dye and spill on both sides. Now you're awake during the procedure, so you'll know your results right away while you're in the room. This procedure, for a lot of patients, we just give a little Motrin. It doesn't take us very long to get it completed. The disadvantage of this procedure is that the dye can sometimes make it hard to tell if there's something inside the uterus that we need to take care of. And if the tube ends up showing that it's blocked, it may not really be blocked. So we end up recommending our patients do the first procedure I mentioned, the hysteroscopy with tubal catheterization, just to make sure the tube is really blocked. Because if we can't pass a catheter through, then that's suggesting that it really is blocked. And with an HSG, a blockage doesn't completely mean that the tube is completely not going to be able to be used in the future. We probably want to do some further clarification. But bear in mind that some OBGYNs will start you off with the HSG. If it's normal, some patients will go ahead and move forward. If it's not normal, we're going to want to bring you back to the first procedure I mentioned, the hysteroscopy with tubal catheterization. And then for the male evaluation, we recommend our male patients consider a semen analysis. So the semen analysis for our male patients is basically is looking at a couple of parts when it comes to the sperm analysis. So we're looking at volume, that's the amount of sperm. We're looking at concentration, so that's the number of sperm per volume. We're also looking at motility, so we're looking at how the sperm are basically moving. Progressive motility is basically the sperm that are moving straight. We have specific parameters and numbers that we look for that basically put a semen analysis in a normal range. What you actually see on the screen here is sperm morphology. So it's the shape of the sperm. We want to see 4% or more normally shaped sperm. So we're looking at structure of the sperm head, neck, and tail, and the ratios. As you can see here, abnormal sperm have big head, little head, two tails. And these abnormal sperm may actually have difficulty basically fertilizing the egg. So when we see morphology, we will talk to you about what causes it and some recommendations on how to treat it and what treatment options would be needed long-term for any of the abnormalities, whether it's morphology, motility, or concentration.
So I'm going to talk to you. So again, thank you for joining us tonight, and hopefully the session is informative. So the first treatment option that I will talk to you about is an Iui cycle, or it's an abbreviation for intrauterine insemination. So this cycle occurs with donor sperm. So the idea is it's helpful because essentially the goal of the cycle is to maybe get people to ovulate who don't normally ovulate, or follow a natural cycle for the one egg that we all release every month as females, or utilize the use of medication to maybe increase the odds by making more than one egg, but not too many. And then that is paired with timing the ovulation and injecting the sperm inside the uterus. So every month we have, and we release, if we're ovulatory, meaning we release an egg every month, or we have regular cycles, we release one egg, and that comes from this fluid-filled sac in our ovary called a follicle. So we can, for people that have regular cycles, we can do this without medication, meaning we monitor your body's normal development of that follicle. And the way we monitor our cycles is the same for any treatment cycle. It involves ultrasound and blood work. So the ultrasound measures the dimension of the follicle within the ovary as it grows. And as the follicle grows, your estrogen increases. Usually most people will ovulate above 2 centimeters. So that's kind of our target goal. So if we're following your normally body essentially ovulating its own eggs, we can let you ovulate on your own and then do the insemination, or to help time things better, we will give you a trigger shot, and that causes ovulation 36 hours later, and then we'll do the insemination. With the medicated cycles, so for somebody that doesn't have regular cycles, they may need medication in order to induce ovulation, meaning grow that follicle, or medication may be used to grow more than one follicle, but usually not much more than 2 or 3 because of the multiples risk. So it mirrors a natural cycle, meaning the cycle or the process starts on your period. By mid-cycle, we're usually doing the insemination, and then your pregnancy test is approximately 2 weeks later. So it mirrors a cycle or a month. The insemination itself is a very easy procedure, easier than a pap smear. So we use a catheter that is smaller than the point of a pin, and we pass it through the cervix and into the uterus. So we're injecting the sperm in the uterus, which has a higher success rate than, for instance, if you were injecting into the cervix or directly into the vagina. And this is done with the use of donor sperm. So donor sperm can be from somebody who is a known donor, so somebody that you know, or anonymous. The anonymous are purchased through donor sperm banks. There are many different donor sperm banks, and you can query donor sperm based on many different attributes: race, ethnicity, education, physical attributes. And these donors are all screened in terms of medical history, infectious disease labs, even their genetic kind of carrier conditions. There are two things that you would pay attention to, and one of them is their CMV status, and one of them is their genetic carrier status. And as part of your initial female evaluation, if we're using donor sperm, we'll also screen and test you for CMV. So CMV stands for cytomegalovirus. It's a virus that most of us have all been exposed to. We would have never even known we had it, and we develop antibodies to it. So depending upon whether you have the antibodies or not will help kind of filter what sperm options would be available for you. And the genetic carrier screening is important because most of our diseases are recessive diseases, such as cystic fibrosis or sickle cell. So you can be a carrier and not know it. So as part of your initial workup, you will get that evaluation. And also the donor commonly gets screened. So for instance, if you were looking at one of the donor banks and the donor that you would like to use as a carrier for sickle cell, then you would need to be screened for that condition. Known donors require a little bit more legwork on your end in terms of the evaluation, because with the banks, they've already been pre-screened. So with known donors, they are evaluated by us in terms of their history. They also get assessed with a semen analysis, their infectious disease labs, and then to protect everyone's rights, they obtain a psychology consult and legal consult also. So that's kind of the overview for IUI cycles, or intrauterine insemination cycles. And then the other kind of treatment option that we have is IVF, which Dr. Hoff's going to review with you.
Hi, everyone. Thanks for coming in tonight in our 2020 primary gathering format. We're really glad you could tune in. We're all obviously very enthusiastic about LGBT fertility support and family building. I get to talk to you tonight about the process of IVF, and then I'm going to talk to you specifically about reciprocal IVF with lesbian couples, and then Dr. Clapp is actually going to talk about using a gestational carrier for our gay couples. So we'll talk about that process now. In general, IVF, what's IVF? So it is a very broad summary, is that it is using injectable hormones to stimulate a woman's ovaries to grow multiple eggs at the same time. Those eggs are retrieved, they're grown in an embryology lab for 5 days, and then they're transferred back into a uterus. So we're going to break that down, okay? That's the 10,000-foot overview. So when we're starting IVF, we do the initial evaluation, as Dr. Nurudeen and Dr. Clapp talked about. And one of the things that we do is assess ovarian reserve to determine what dose of hormones we're going to be using. Now, every month, you ovulate one egg, as Dr. Clapp was telling us. Now, what you may or may not know is actually on both of your ovaries, you have a group of eggs that start growing. And they're all competing to be this one that ovulates. In a normal month, in a woman, she will ovulate one egg, and then the rest of them will dissolve. So when we're doing IVF, we are actually trying to bring all of those eggs up to the point where they are considered to be mature, meaning that they could be fertilized. So how do we do that? We do that using injectable hormones. So this is kind of an example of one of the pens. This is an injection of exactly the same hormone that your brain uses to tell your ovary to grow an egg. But now, because we're giving you more of it, your body will actually allow more than the one egg to grow. And ideally, we're going to get most of those little eggs that we're all competing to grow up along with us. So as I said, we get a number of eggs to grow at the same time. We'll do the monitoring, as Dr. Clapp was saying, with your ultrasounds. So we would do ultrasounds and blood work to measure your hormone levels and make sure that they are rising appropriately. Typically, most women will need 7 to 14 days of injectable medication. Now, it doesn't make a difference in terms of egg quality or embryo quality, whether you take 7 days or 13 days. It really is just how fast your body grows the eggs. So the injections are given over those 7 to 14 days. The most common side effects associated with those medications tend to be those that we notice with higher levels of estrogen. So, you know, some women will have some breast tenderness or nausea. Some women might get some mild headaches or just feel really tired. And some women might notice some mood changes. Most of the time, these hormones are very well tolerated. The side effects are mild. And the process of time from the injections to the retrieval, as I said, varies about 1 to 2 weeks. But when we see that the majority of the eggs are of the size at which they'd be mature, that is when we would plan for the trigger injection and then plan an egg retrieval approximately 36 hours after that trigger. So the egg retrieval is a procedure that is done under anesthesia, and it's done with the transvaginal ultrasound. So it's the same ultrasound that we use for monitoring your progress during the cycle, except this one will have a very fine needle attached to it that will allow us to collect the egg. And the egg will be obtained and in a tube, which will go to the embryologist, where the embryologist will basically clean off the egg and fertilize it several hours later, and then they will continue to culture it in the lab. So I'm going to go over that here in a minute. Once we do, the final part of IVF here on the slide that you can see is the embryo transfer. So I'm going to talk about that here more in a little bit. But first, I want to go over the progress of the egg to the embryo development. So here you can see that first picture is what a mature egg looks like after it's cleaned off. And then the egg is fertilized several hours after the retrieval. That second picture there is actually showing successful fertilization. And then you go to around day 3, the embryo should be approximately 6 to 10 cells. And then they continue to culture until we get to what's called a blastocyst embryo. And this is what you see on day 5 or 6. This is actually a time when the embryo has 2 components to it. The outer envelope component is the portion that will become the placenta and nourish the pregnancy. The inner portion is the inner cell mass, which becomes the baby. And so part of the reason that IVF has become so successful is that we have obtained the ability to culture an embryo to day 5 or 6. And day 5 or 6 is exactly when natural implantation is anticipated to occur. Basically, the uterus is expecting implantation on day 5 or 6, and that's exactly when we put the embryo back. So that has significantly increased the success rates of IVF. So we do have this option on day 5 or 6 of actually genetically testing the embryo. This is optional, but I will talk about that as this is a very common question. The process involves taking several cells from the outer portion of the embryo. So as we mentioned here, there is let's see if you can see this, the inner portion and the outer portion. So we would take cells from this outer portion, leaving the embryo alone, and those cells would be sent off for testing, and we would analyze to make sure that the embryo had the normal, correct number of chromosomes, didn't have an extra, 21 for Down syndrome, some extra other trisomies that can result in syndromes, or be some combination that typically results in a miscarriage. As part of this process, we do find out the sex of the embryo as we analyze the chromosomes. That is something that you can choose to know or not, and you can actually choose if you want or not. And so that is the process of genetic testing for the embryo. Those results typically take about 2 weeks. So after the retrieval process, we allow women's hormones to calm back down, get back to their baseline level. Then she has a period, and then depending on what's happening, so if we're doing reciprocal IVF or if we're doing autologous IVF where we're doing transfer back to the same woman, then that is the time that we prepare the uterine lining for transfer. So we'll talk about reciprocal IVF a bit here, and then I'll talk a little bit more specifically about the transfer process. So reciprocal IVF is something that's really cool. It's a really unique aspect that lesbian couples get to both physically participate in the pregnancy. So one of the really unique things about lesbian couples is that you actually have two potential egg donors and two potential carriers of the pregnancy or gestational carriers in each couple. So, how you choose to use that combination is totally up to you guys. Of course, you can do insemination with one or reciprocal with the next. So, it just depends on your preference. But reciprocal IVF basically would involve one of the women to go through the IVF process, as we've talked about. And the other woman would actually be the carrier for the pregnancy. And so she would have her lining prepared for transfer. So basically that process initially is very simple and would involve 2 weeks of estrogen pills and patches. And then we do a couple of ultrasounds to make sure that the lining for the uterus is nice and thick. Once we know that that lining is nice and thick, so it's now a nice pillow for this embryo to land on and implant, then we would start progesterone injections, and those are done for 5 days before transfer and continue through early pregnancy. So this is a process where, once pregnancy occurs, then we would do monitoring for the first trimester. So the first 12 weeks would be spent here with us at HFI. We would follow you very closely in terms of your hormones, we would do weekly ultrasounds once we're able to see something on the ultrasound. It's of course our favorite part of our job, so we love it very much. So this is something that I'm really excited to share with you. My wife and I are in the middle of this process right now, so can kind of speak to you from both the patient and the doctor side, but I really think it's an exciting option that we get to offer folks. Dr. Clapp is actually going to talk about a great option that we have for gay men. So I will let you go ahead and get started.
All right. So for our gay couples, we also have a very successful option in order to accomplish your family building goals. So it involves the use of an egg donor also and a gestational carrier. So egg donors, similar to sperm donors, can be anonymous or they can be known. Anonymous egg donors, you can purchase eggs fresh, meaning you pick an egg donor and they go through an entire IVF cycle. We retrieve the eggs like Dr. Hoff spoke of earlier, and then all of those eggs, would be fertilized and embryo created. Or you can also purchase frozen eggs from donor egg banks. And we have a donor egg bank at HFI. There's also other donor egg banks across the country that you can utilize if you're looking for specific attributes that we may or may not have within the donor egg banks. Known egg donors, similar to known sperm donors, will do an evaluation. And that's just to also make sure that they would be a good candidate to donate eggs. So these are usually younger women where the ovarian reserve would also be good, and also their quality of eggs would be good. So the assessment is similar to what Dr. Nurudeen spoke of earlier regarding their ovarian reserve testing, their AMH, their required infectious disease labs, and that evaluation. So once you get the donor egg, you can then fertilize that donor egg with the gentleman's sperm. Either you can split it and do, sperm from one person or both partners. And then you're going to utilize a gestational carrier. So we would help you provide or set you up with lists of gestational carrier agencies, and you're matched with them. So because you're going to be spending a long time with them, an entire pregnancy. So you want to make sure, that you're comfortable with your gestational carrier, and then they will be passed on to us to assess. So when we receive notification that you've selected a gestational carrier, we will then evaluate them to make sure that, the end goal is a healthy pregnancy, but also that, we're not going to do any harm to the gestational carrier. So ideally, it's been somebody who's had a child before, had an uncomplicated pregnancy, also someone that doesn't have, chronic medical problems that would or could affect the pregnancy or in general their health. Once that carrier has been screened, meaning checking her uterus, similar to the cavity checks that we discussed at the beginning of the lecture, then they go through the transfer process similar to what Dr. Hoff discussed. So we would build up their lining of the uterus and do the embryo transfer. And then we would follow that pregnancy through the first trimester. Commonly, people come to the transfer with their gestational carrier and also to ultrasound visits, which is completely fine and welcome. And then you would graduate back to general OBGYN for the remainder of the pregnancy. And that kind of sums up our gestational carriers. And then I think we're going to talk about one more topic in terms of fertility preservation.
Dr. Nurudeen, you are still muted.
I was trying to keep the background noise low. Hope you can all hear me.
Yep.
So I'm going to talk a little bit about fertility preservation and reproductive options for our transgender patients. Fertility preservation is opportunity to freeze eggs, sperm, or embryos for later conception. This is recommended for those individuals who would like a genetically related child in the future. Currently, we have many transgender persons who are of reproductive age and late adolescence at the time of their transition. And of course, many wish to have children after transitioning. Ideally, freezing eggs and sperm or embryos, we hope to occur before beginning the transitioning process, but we totally understand that this may not always be possible. Transitioning is unique and it's going to be tailored to the individual. So depending on where you are with your transition process, or also known as gender affirming care, physically or even emotionally, we will help with the planning and execution of your freezing process. Some individuals may not have chosen to transition surgically, but it may have started the hormonal process. The goal of the hormonal therapy is to basically maintain the normal levels of your target gender. So this may affect production of eggs and sperm. So at this time, we recommend discontinuing hormones for maybe 3 to 6 months before starting the freezing process. So for our transgender female, male to female, we recommend 2 to 3 ejaculated samples to provide an adequate number for future use. We examine each collection and divide it up into vials that can be used for future insemination or IVF. If the future partner is a male, we'll help the couple plan for egg donor and gestational carrier like Dr. Clapp discussed. If the future partner is female, we'll discuss the options of insemination or IVF. For our transgender male, female to male, we recognize egg freezing as an option if they have not undergone removal of their ovaries yet. If they've already started hormonal therapy, we recommend they start the hormones before starting the medications needed for egg freezing. Ovulation can return within 6 months for 80% of patients, but it's not a guarantee. We may have to wait longer. For egg freezing, just like was discussed earlier with IVF, you'll take injection hormones for 10 to 12 days before the egg retrieval. Once the eggs are retrieved, you're done. If the future partner is male, we can fertilize the eggs with his sperm, and they as a couple can decide if they want a gestational carrier. If the future partner is female, they can use donor sperm to fertilize the eggs, and they as a couple can decide if the female partner will want to carry the pregnancy. This is similar to reciprocal IVF that Dr. Hoff discussed previously.